So this is a joint, collaborative audit between the National Diabetes Audit for Adults and the NPDA. So you haven't had to submit any extra data. All we've done is to link patients across years and look at what happens to them as they go through transition. And this is the second time we've done this, and it's far more powerful this time because we've used the actual date that you gave us where the person transferred from paediatric to adult care. So we've been able to define that change much better. And then this audit data is going to be followed by Sarah, who's our transition lead for in Wales, who's going to talk about the work she's been doing around standards. And then we've got two people who come from Merthyr Tydfil, Lucy and Vicky, who Merthyr Tydfil is one of the best performing centres in the National Paediatric Diabetes Audit, and they're going to tell us about how they've changed their transition model. So David showed this slide, and he asked if anyone had seen it before, and there was a couple of hands. By the end of today, you're going to be bored with it and fed up with this slide because you're probably going to see it several times. So this is HbA1c data from the Type 1 Diabetes Exchange against age. And as you can see, they're from cohorts under the age of 5 or 6, have an HbA1c around about 64. That goes up in adolescents to around 74, a 10 millimole per mole difference. So that peak is exactly the time we're transitioning people into adult services. So it's probably the worst time to actually do it, but we do it because that's the way our healthcare systems work. And there are this massive brick wall between paediatric and adults, which we have to try and change into a garden path that you can just walk down seamlessly. I haven't got a graph like that from the NPDA, but I have got this graph from the NPDA data, which shows something rather similar. So this is, again, HbA1c broken down by age. I'm not sure if can you see a pointer in there? No, you can't. But if you can see down in the under 5s, you've got a mean HbA1c of about 60. By the time you're down into late adolescence, it's around 70. So again, a 10 millimole per mole difference in HbA1c in those age groups. So to an audience like this, I hardly need to tell you why this transition from paediatric care is important. It's about supporting lifelong management of that condition. It's essential in achieving the most positive outcomes for an individual person. And people making that transition from childhood to adult are particularly at risk of that disruption in care. There are lots of things happening to them. They're leaving school, they're going off to university, they start to have relationships, and all sorts of things happen. And this will affect their short and long-term health care. And so that engagement between paediatric and young adult services is essential to provide the continuity of care. And if you fall short of that, your blood glucose levels poor, and that has subsequent consequences on increased risk of morbidity and mortality. How many people here are from adult services? 2. So I'm talking to a paediatric audience, but I'm going to show you some data because we think we know how to do it in paediatrics. I'm going to show you that actually that may not be the case. So I said this is the second published report. It's taken data from 2011-12 right up to 2016-17. It's just focused on type 1 diabetes. What we've tried to answer is the transition from paediatric to adult care associated with changes in care process or healthcare check completion rates? Is there a change in achievement of treatment targets, and are there any changes in rates of diabetic ketoacidosis? That's not a diagnosis, this is recurrent episodes of DKA. So the first bit is about how did we identify those patients and what are the age. So this shows there were 3,800 patients that we were able to link across the two audits that had been in paediatric care, they'd gone through they had a transition date, and they'd done at least a year post-transition. We've actually got data up to 3 years, but the numbers are beginning to drop off a little bit at 3 years post-transition. 3,800 children, young people who transition between those ages. You can see around about 2/3 of them are transitioning sometime around the age of 17, 18, a few quarter down below the 15, 16 age group, and a few up into the 19s and 20s. This data is now quite tight because we know the exact age of transfer, whereas when we published 2 years ago, you can see there were a lot of children around about 12, 13, 14 that we thought were transferring. That's purely because the only mark we can use last time was they were in the paediatric audit and then disappeared and reappeared in the adult audit. It wasn't ideal, but that's all we could use. So it's much tighter now, and I think probably anecdotally, I think that probably is what's happening across the country. So what percentage of young children registered with type 1 diabetes are receiving their National Institute of Clinical Excellence key processes for diabetes care? And the key processes are pretty much identical for the paediatric and for the adult services. So each of these groups represents the care process. You've got H1C, blood pressure, urinary albumin, foot checks, retinopathy, smoking, and body mass index. In each of those columns, the code is the same. So, can't see it. So on the left here, you've got the year post-transition. This is the year of transition, which is the grey bar, and these are the 1, 2, and 3 years post-transition. And pretty much during the actual transition year, the rates remain pretty much the same as they were pre-transition. But as you can see in most of these, there's then a drop-off. And generally, there's about a 5 to 15% reduction in the completion of care processes in the first year following transition. It doesn't improve much in the second and third year. And we sort of thought we knew that. We know that anecdotally. Most of us who work in that transition know that things don't improve. From that, this is national average data, so you might think, well, we know how to do it in paediatric practice, we're pretty good at that, and when they disappear on the adult services, they don't know how to do it. But in fact, there is a huge variation by unit. And so in some areas, there is improvement post-transition, and in some areas, there is a falling off post-transition. And these whisker plots here show that so that if there is no change, you stick with the green line in the middle. If you go above that, there's a greater completeness post-transition, or you go below it, there's a greater completeness before transition. So although on average it's greater completeness before transition, there is huge variation. Now, published yesterday was the unit level data. So has anyone looked at this? Holly and me were here last night looking at it. So you can, when you go onto the website, it says service level data. So you can click on, you know what your PZ number is, it actually gives you names your units. So you can pull your own data off, and you can look at this both ways. You can look at your patients from your paediatric centre who've transitioned, and the adult service can look at what's come to them and see what's happened. So you can see whether you're in that better rate or worse rate. So I've just put up here, I've put up my own centre, University Hospital of Wales, because I didn't want to embarrass anyone else. So we transitioned here 75 children, 70 of which had type 1 and 5 had type 2. This amongst that 3,800 children. And all I've just shown you is the first one, which is completion of HbA1c. So the bar on the back here is the England and Wales combined data. This is, the blue is my unit, so we're doing slightly better than the national average pre-transition, slightly better than the national average during the year of transition, but then you see the first year post. So we're one of those units who are not doing as well. You must go and have a look at your own centre and discuss that with your adult colleagues. So the comment from the care processes, before I move on to targets, is in general, completion of care processes falls after transition from paediatric to adult services, and overall, during the year of transition, completion rates either improved or stayed the same, and then deteriorated. There are substantial differences between services, appreciable improvements during transition in some, even though these are outnumbered by those that deteriorate. And we need a better understanding. I don't understand why that might happen, but as you know, anyone here taking part in the NDTA QI programme at the beginning of February. Good, so some PJ, and you should be bringing your adult counterparts to that. So that's going to try and support that, and also there's the QI that's going on within the RCPCH for paediatric services. So what about targets? And I'm just going to show you the HbA1c target. You can also on the slides which are on the NDA website, you can look at blood pressure targets and cholesterol targets and other things as well. So this is the data from the NPDA. As it's been shown this morning, there are massive improvements over the last 8 years. So this goes from 2011 down the bottom here right up to 2016, 17. There's been an almost doubling in children achieving an HbA1c less than 58, and almost halving of those with an HbA1c above 80. So that's all good news. But is that all in vain? Because what happens to them after they transition? So the bar on the far left is the year before transition, around about 28%, achieving HbA1c of 58. Falls a little bit in the year of transition, but then continues to fall. So less and less are achieving that. So it fits with that graph that David showed, but in a way it's almost worse because he's actually beginning to show some improvement after that sort of 18, 19 age group, whereas ours seems to be getting a little bit worse. Once again, of course, there is huge variation, and in some centres they're actually getting better. So you might think you're doing well in paediatric practice, but your adult colleagues might actually be doing better than you. So it's not all of us who are improving, and you need to go and look at that online tool to look at your own centre. So this shows you the variation. Those above the line, greater achievement after transition; below the line, greater achievement before transition. So what can we take away from that? I think there's a need for paediatric and young adult services to address the overall decline in the target blood glucose control post-transition. Remembering that deterioration during transition is not universal. So your young adult clinic may be doing better than you, and you might learn from them. We need a better understanding, so do come to these quality improvement collaborative support processes. And I think you could put a list as long as you are for important factors, but there is a need for paediatric and adult services to work together to ensure the key messages are maintained during transition, and maintaining engagement probably is the most important thing during transition. We all know about this so-called lost tribe that disappear and then reappear in their mid-20s with retinopathies, microvascular disease. We need to keep them engaged. So finally, diabetic ketoacidosis, hospital admissions. These are not at diagnosis, these are recurrent episodes of DKA. So again, the far left is the year before transition, the next bar is the year of transitions. There's an increase in DKA rates during that year that we transfer, and then it goes up a little bit the first year and then come down a bit. And although those are only 1 or 2% differences, over that 3,800, that's actually quite a lot of extra admissions with DKA. So on average, young people with diabetes experience deteriorations in the annual care process completions. There's a deterioration in the achievement of targets and higher rates of DKA while transitioning from paediatric to adult services. However, that overall picture is the sum of considerable local service variation, and whereas most services demonstrate these adverse trends, a large number continue to show the opposite. So these are the recommendations that have come from that audit, and Bob Young and I and colleagues from NHS Digital, and there are some representatives from them here today, took a bit of time thinking about this. So the recommendations to the clinical commissioning groups in England, local health boards in Wales, is to look at how your local paediatric and adult services compare with others in England and Wales. So that's where you go out and do your QI projects. And if required, so if you've got deteriorations, you need to support them in achieving better outcomes. And the messages for us really are to work collaborative, compare yourselves to other services around you, go and have a look at their transition models. We're going to hear about one in a minute. and just consider how improvement might be accelerated through participation either the college or the NDA quality improvement collaboratives. So I always get to do the nice job of just stand up here and present, but this has been a big collaborative with NHS Digital, lots of telephone conferences, a lot of sharing of the analysis. So I'm grateful to them, also all the people in the RCPCH who do this, and HQIP who fund all this, and you as the taxpayer who fund HQIP. So thank you very much.